I'm Sakina Shaikh, currently serving as the president of the Student Interest Group in Neurology, and I will be hosting today. Today's episode titled Beyond ICU, the Practical Guide to Neurocritical Care. So we are having Dr. Joshua Kornbluth for this episode today. We are pleased to have him. Thank you so much, Dr. Kornbluth, for joining us today. Dr. Kornbluth is currently serving as Associate Professor of Neurology and Neurosurgery at the Tufts Medical Center. He's also serving as the Vice Chair of Education and Training at the Tufts Medical Center, and also serving as the current Program Director of Neurology at Tufts Medical Center. Thank you so much for your time, Dr. Kornbluth. We are truly honored to have you.
Yes, please. Thanks so much for inviting me.
Thank you. So before we dive in, I'm just curious to know what was, looking back into your journey, what was that particular thing that attracted you towards the neurocritical care, and what inspires you towards it today?
Yeah, thanks for asking. It's an answer that's largely the same since I entered medical school, but has changed a little bit over the years as I've learned a new perspective of the patients I care for. Before I went to medical school, I was an EMT. I did pre-hospital care. I brought patients to the emergency room. I got really interested in acute and critically ill patients. But I always had an eye for neurology. In college, I majored in neuroscience and psychology. I minored in philosophy. And I thought, honestly, I wanted to do either emergency medicine or neurosurgery initially. And then in the summer after my first year of school, I was fortunate enough to have connected with a neurosurgeon who allowed me to work with her to do a summer research project. And I got to go to the operating room as a first-year medical student. And doing a craniotomy and doing a durotomy and seeing a living brain was probably the coolest thing I'd ever seen in my life. But the next few hours of standing in place over a microscope doing microdissection bored me to tears. And I knew I wouldn't be interested in it. And spine surgery is definitely not for me. And so I knew I wanted to do neurology. So I entered my second year of medical school in my preclinical years thinking I want to do clinical neurology. But still feeling a little bit lost, feeling like there was maybe a piece missing. And then in my third year of medical school, I was discussing with my mentor what I like about clinical medicine. And it was sick patients, the conversations with sick patients, conversations about, comfort, conversations about prognosis, conversations about personalizing care. But I liked doing some procedures. I liked, being in the thick of it. And so my mentor said, have you considered neurocritical care? And I said, no, I've never heard of that. And so she set me up with someone in the field to work as a clinical rotation and to mentor. And the rest is history. I started my residency knowing exactly what I wanted to do. I went to my residency making sure I had a strong foundation in the fundamentals of general neurology. And then I went on to fellowship, and I've been a practicing neurointensivist since.
All right, that's really inspiring to hear, especially first you were interested in neurosurgery, then you transitioned to neurology, and then what made you to pursue neurocritical care specifically. Thank you so much for your answer. Moving towards the next question, one challenge many students face and junior trainees also face that is simply knowing where to begin when a critically ill neurological patient arrives. So could you please walk us through a systemic approach to evaluate such patients?
Sure. I think the premise is a little confusing right now, because you asked about identifying how to care for the critically ill patients. And I think it needs to start with recognizing whether the patient is critically ill or not. That is one of the things that is special about our field, is someone could have a devastating brain injury, but otherwise look fine externally. Someone could be having, a major stroke and look like they're lying with their eyes closed. And so being vigilant that a critical process is proceeding, I think, is the first step. And so whenever we're consulted, even if someone else hasn't said, well, this patient is critically ill, I need you there, we have to assume there may be something going on that's leaving them at risk for severe acute neurological deterioration that may impact their outcome negatively, if not survival. So the first step is maintaining a high level of vigilance for someone with neurological changes to disentangle, is this a critically ill patient or not? The next step is identifying what the primary driver of the injury is and understanding if we can reverse that. For instance, a large vessel occlusion, an acute ischemic stroke, or if we can't reverse it, but we need to remain vigilant and prevent any secondary damage. For instance, someone with a traumatic brain injury who has intracranial hypertension, I need to do things to try to restore blood flow and bring down intracranial pressure to try to give the brain the best chance at recovering. So understanding if it's something I can do now to fix a problem, or just I need to be vigilant for ongoing secondary damage and be aware for that and give the person the best chance of recovery is important. There are a few things that we need to look out for as neurologists. So if someone has altered mental status and they're hypertensive and bradycardic, you should assume they have intracranial hypertension until proven otherwise, and use maneuvers to treat that. Things like mild hyperventilation, if you're able to, maintaining normal perfusion pressure, hypertonic saline or mannitol, osmotic therapy, if you have them close by. And so the first step is that. And importantly, we need to stick with the basics, right? ABCs, just like in ACLS. Is your patient breathing? Do they have a pulse? Doesn't matter how bad their brain injury is. If they're not breathing and they don't have a pulse, they're definitely not going to recover. So don't forget the basics of acute and critical care medicine, of emergency care, to make sure that they're breathing, make sure they have a pulse. If not, sort those out. If you look at the literature and you look at the guidelines, many times it lists things in tiers or a stepwise approach. And realistically, we often do many things in parallel. So when I'm looking at someone who's hypertensive and bradycardic, I'm sitting them up at 30 degrees, maybe even higher at 45 or 60 degrees to optimize venous outflow from the head. I'm calling for a nurse to help me with sedation. I'm making sure the airway is secure. I'm considering if they're seizing or not. So a lot of these things happen at once, and the ability to do that only comes with time and training.
Okay, that was really helpful, especially the stepwise approach. You mentioned the constant vigilance and then looking for the factors that drive that injury, and if they're reversible or irreversible, then those simple basics of ABC. Thank you so much, Dr. Kornbluth. Moving towards the next question, I guess you partially answered it as well. If you want to add anything related to it, that the altered mental status and coma feels very overwhelming sometimes because of their broad differential diagnosis. So how do you recommend students to approach such patients in a structured and logical way? Do you want to add anything?
Yeah, I think that's a good question. It's a very broad category. Altered mental status is a spectrum. It could be, mildly confused. It could be deeply comatose, or on the other side, it could be hypervigilant, agitated, disinhibited, right? Those are all altered forms of mental status. And so again, we need to figure out on first contact, is the patient safe for me to have the time to figure out what's causing this? And if the answer is no, if they're apneic, secure the airway. That gives me time to figure out what's causing this. Do they have a normal perfusion pressure of the brain? Are they hypotensive? If no, fix that first. If there is no known cause for the altered mental status, we need to start doing a diagnostic workup quickly. And some of that is going to be predicated on the immediate history. So for example, someone who's been in the hospital, receiving a lot of medications, and they're confused, disoriented, inattentive, but their vital signs are stable, we have time to take a history, talk to the nursing team, talk to other physician teams. What medications have they received recently? Is their renal function okay? Is there a potential toxin on board? That's very different than someone who comes in through the ER who is unresponsive and hemiplegic. And we need to get a quick CAT scan of the head to rule in or out a stroke or a subdural hemorrhage or traumatic brain injury of another form. And so your diagnostic workup, the speed at which you do things in parallel, and the amount of depth you're able to use on your history and physical exam taking depends on the bigger picture of what's going on. It's important to recognize that the answers to your first round of questions don't necessarily lead to the right answers. So, did they hit their head? Are they intoxicated? If someone says no and yes, you don't know. They may have still hit their head. And so when you go and do your physical exam, we look at signs of external trauma. We look at environmental exposure and their temperature and so forth, to always try to reconsider the information that was given to us. Because often what we're receiving, especially for someone who has an altered mental status and can't provide history themselves, is we're receiving information from someone else who took a history or received history from someone else. So trusting what they told you, but verifying, repeating whatever you need to rule in or rule out things in your differential very quickly is critical. And then don't forget about the rapidly reversible things. So, opiate intoxication, using something like naloxone is fairly harmless. And so if there's any concern, we'll do that, right? If you get into a diagnosis of something like delirium, those are usually diagnoses of exclusion, meaning we need to make sure there's not something more serious going on. And at the same time, what I've said about other disease entities is true for someone with altered mental status. We're doing our best to diagnose them now, understand if they're a risk for secondary brain injury. And the treatment of altered mental status in the acute phase is never restore the mentation, right? It's fix the underlying cause. When someone's in a subacute or chronic phase of their acute neurological illness, whether it be in a traumatic brain injury or a stroke, there are certain things we can do to try to augment consciousness and restore normal cognition. But in the early phase, it's understand what's going on, minimize the risks of additional injury by maintaining normal physiology as best you can, coming up with a diagnosis, and then ruling out any confounders, and then trusting by verifying what you were told to make sure you don't miss any opportunities to help your patients.
That was really insightful, especially the part you mentioned that the diagnostic evaluations and the way our approach to patient depends on the status they presented to us with. So moving towards the next critical emergency in the neurocritical care is raised ICP. What are the clinical findings that should immediately raise concern, and what are the initial management priorities in such patients?
Sure, raised ICP isn't the whole story, right? It depends where you measure it and what you're doing. Remember, ICP is intracranial pressure. Intracranial pressure is not a fixed number. There's a systolic and a diastolic, just like our blood pressure. What we usually record and report is the mean over the cardiac cycle of the ICP. So understanding that first is important. Knowing that, like so many other things in the body, it's not just the absolute change, but the rate of change that's important. So for example, someone with what used to be referred to as pseudotumor cerebri, which is now idiopathic intracranial hypertension, which in many patients is a chronic veno-occlusive disease in the head, they may have scary high ICPs in the 20s or 30s or even 40 centimeters of water for months and be very mildly symptomatic. Whereas if someone has a traumatic brain injury and their ICP is 40 now, a day after their injury, their brain is suffering much more. And that has to do with cerebral autoregulation, and whether cerebral autoregulation has shifted to accommodate for that increased intracranial pressure. And so just saying ICP, a high ICP, enough isn't alone. We're going to assume for the purpose of the conversation that it's an acute intracranial hypertension for someone with a normal brain pre-injury. In that case, again, ICP is just a number. There are guidelines and there are generally accepted practices of what numbers we ought to treat in certain diseases. But the most important thing is understand your patient. And so if your patient has known or suspected intracranial hypertension and altered mental status, so depressed cognition, and hypertension and bradycardia, that's an ICP crisis until proven otherwise. Usually we don't even wait to prove it. We treat very aggressively with osmotic therapy like hypertonic saline or mannitol. Secondly, I say that ICP as a number isn't the whole story, right? ICP is a global summation of the pressures in the skull. We know that pressure isn't distributed equally. So if you have a subdural hematoma, pressure is higher on one side of the head than the other, and it can push the brain over. And so other signs or symptoms of localized increases of pressure are herniation syndromes. The typical one that we look out for most is downward transtentorial herniation, also referred to as uncle herniation. And this causes damage to the ipsilateral third cranial nerve and causes a dilated pupil. So if you have someone that, if we're taking care of someone that we think is at risk for intracranial hypertension or herniation, we pay very close attention to their vital signs and their physical exam. And if we see depressed level of consciousness and newly asymmetric dilated pupils or bilateral fixed and dilated pupils, that's a big red flag that intracranial pressure is rising first on one side, causing the ipsilateral pupil to dilate and rapidly translating to intracranial hypertension on the other side. And eventually that's going to decrease real perfusion pressure and lead to more brain injury.
Okay, that completely makes sense, and especially because you mentioned that ICP is just a number and summation of the pressures of the brain. What makes it significant or not significant as the factors, other factors that are present in the patient, especially the changes in the pupil and the mental status. Yeah, truly appreciate it. Moving towards the next question, that they say this as epilepticus is one of the neurological emergencies. So from a practical standpoint, what should every medical student know about recognizing it and managing it?
Yeah, I can talk for hours on status epilepticus. It's a really important question. I think the most important thing is status epilepticus is a neurological emergency. It needs to be taken very seriously. You know, the dichotomy you see in the room when someone is actively seizing in front of a neurologist is everyone's going a little bit crazy, but the neurologist are paying attention because we're looking at the patient. We're trying to understand the seizure. We're trying to understand what the semiology of the seizure is, so we can try to localize and understand where it's coming from while we're getting ready to treat the seizure itself. And so the first thing to know is that just because we are not panicking and running around like crazy doesn't mean we're not taking it very seriously. Status epilepticus has a few definitions. I think that's also important for students to know. Most of these definitions are to get patients into clinical research trials, and to have a shared vocabulary of what is status epilepticus. And the two most common defined definitions of status epilepticus are a single seizure lasting more than 5 minutes, or seizures back to back without a return to normal over 30 minutes. And so those are helpful to sort of wrap your head around, might this be status or might this not be status? Other really important things for students to know is benzodiazepines are the first and best line treatment for status epilepticus. And so usually we as neurologists, if someone is having a seizure, and for the sake of this conversation, we'll refer to it as a generalized tonic-clonic seizure. That's the common vernacular for the types of motor seizures that we see most commonly. We usually wait about 2 minutes before we treat from the onset of a seizure, since most seizures will stop on their own, right? Remember, but most seizures are self-limited. So usually at about the 2-minute mark, you should be thinking, okay, I might have to treat this now. And you should be asking other members of your team to help get a benzodiazepine, whether it's midazolam or lorazepam, and ask them to drop 2 or 4 milligrams. Coming into the 2 to 3 minute mark, if it's not stopping, especially if it's a first time seizure, you should be asking them to give it. When you're giving a benzodiazepine, also be thinking, what other medications might I need to be using to stop these seizures? Those are things like levetiracetam, things like phenytoin, things like valproic acid, things like lacosamide are the common ones we use. So status epilepticus is a neurological emergency. We need to treat it aggressively. Some seizures will stop on their own, but once it crosses in about the 5-minute mark, most won't, and we need to be very aggressive with benzodiazepines, followed quickly by a traditional anti-seizure medication. The last thing I want to say about this is all that is the general approach. Every patient must be taken individually. A young, healthy 20-year-old patient now has seizures as in status is very different than someone, of advanced age with heart failure and cardiac arrhythmias and renal failure, and they're much more vulnerable to the physiologic effects of ongoing seizures. So we may choose to treat a little bit more aggressively or a little more permissively to allow changes in vital signs based on some of the underlying physiology and underlying pathophysiology of the individual patient. So not only is status epilepticus a true emergency that should be treated very aggressively, we still need to personalize care and understand the implications of our treatments on our individual patients.
Really appreciate your detailed response to the question. I just want to move towards the next question. Modern neurocritical care relies heavily on technology. So could you explain the role of EEG, the intracranial pressure monitoring, the neuroimaging for including neuroimaging and guiding management? How do these investigations complement rather than replace the neurological examination?
Yeah, I think the way you framed it is really important. We should not treat any diagnostic tool as a replacement for our physical exam. It is an extension of our physical exam. So I was not lucky enough to be born with X-ray vision, so I use X-ray machines and CAT scans to help me with that. We're very fortunate now that the physicists and the radiologists have developed technology to allow us to look in the brain with MRI machines, and so we use MRIs. There's different ways to understand all these different modalities as extension of our physical exam. One is, are we looking at anatomy or are we looking at physiology? When we look at physiology, are we looking at vascular physiology and cerebral blood flow, cerebral perfusion, or looking at electrophysiology like EEG, EMG, somatosensory potentials, somatosensory evoked potentials, things like that. Recognize that everything has a consequence. For my critically ill patients, MRIs give us great pictures, but moving them out of the ICU into the MRI machine for someone who's very fragile may be a risk. And so like everything else we do, it's risks and benefits. We do a lot of bedside monitoring. We can do point of care ultrasound of non-neurological anatomy and physiology, cardiac echo, pulmonary ultrasonography, things like that. We can do optic nerve sheath diameter measuring with ultrasound to give us clues about intracranial hypertension. We can do transcranial Dopplers or transcranial Doppler sonography to try to get a look inside the skull at the bedside with an ultrasound. We can do various other forms of multimodal monitoring, including invasive monitoring, invasive ICP monitoring, invasive partial pressure of oxygen monitoring, so brain tissue oxygen monitoring, cerebral microdialysis, non-invasive or invasive electrophysiological sampling, so scalp EEG, what most people think of when they think of EEG, or invasive monitoring to get really high resolution electrophysiologic information from an injured brain. All these to say is you have to know what question to ask with the tool you're. So when I'm examining someone who has a new onset focal neurologic deficit, I'm thinking, are they having a stroke, for instance? And so my exam is tailored to, are they having a stroke? If I can't answer that, which I usually can't if I don't have a patient without a CAT scan, they get a CAT scan. The CAT scan can then help me answer, are they having a hemorrhage in their brain or not? Right? CAT scan is very good at looking at acute bleeding. It's not very good at looking at acute infarction or penumbra. So I have to move to a different test, a CT perfusion scan, for instance, or a CT angiogram that can augment my information. So just like when I'm doing a hypothesis-driven neurological exam, I start with mental tests, the cranial nerves, motor and sensory, reflexes, and so forth. And everywhere along the way, I'm shifting. What is the next question I'm going to ask, and how am I going to ask it and answer it in my physical exam? The same is true for any imaging or ancillary study I'm going to be doing. My CT, my CTA, my CT perfusion, my MR, my MRA, my MR perfusion, et cetera. They're all going to serve to help extend parts of my bedside physical exam that I just don't have the tools with my own senses to help answer. More continuous or semi-continuous monitors like intracranial pressure or partial pressure of oxygen in the brain. Snapshots are very important, just like a single head CT is very important, but trends over time can often give us much more robust information. And so the last thing I'll say on this is trends over time often help us sort of back up and zoom out and look at and look for signals that we might have otherwise missed. And no single tool is going to change outcomes for patients, right? It's how that tool is used in the hands of the care team. The doctors and nurses and the PAs and NPs, everyone else who's part of my team is going to use that information to apply to their patient. And you should very rarely rely on the information from a diagnostic tool alone to make a decision. It should be taken in the bigger context of what's going on with your patient.
Okay, that all makes sense, especially because today, in the days where we have like diverse technologies to help us with, but it all depends on how much good history and examination. It all depends on that thing, what that next diagnostic tool we are like choosing. So moving towards the next question, and that I'm really interested in is neurocritical care is evolving rapidly. Looking ahead, which emerging advances or the research areas you are currently like most excited about?
Yeah, that's an interesting question. I'm going to give you my answer today. And I'm saying that because almost, every week I learn about something new that gets me excited. I think the biggest tool we have right now is we capture so much data in the neuro ICU, whether it's continuous blood pressure or continuous ICP or heart rate or heart rate variability. Our neurological exams, the nurses are documenting a neuro exam or a Glasgow coma scale every hour. There's so much data, and analyzing that is so hard, right? You used to have to ask a very specific question of your data. Do people who come in with a certain illness have elevated ICP over the first week of their stay, right? We have data, we can look at that. The innovation now is large language models and generative AI and machine learning. For the first time, there's a possibility to take raw data. I could have 10 million data points for my patients over 5 years with a diagnosis and an outcome, and feed it, to generative AI models and say, look at all this data. What signals haven't I seen? What am I missing? And be able to ask it, maybe, subtle changes in heart rate variability could predict incidence of cerebral vasospasm. I don't know. Right? Instead of me having to ask the questions individually and doing a study, I can back up and say, here's all the data. Find me some sort of signal correlating with a change or an outcome, and then not trust it, but use that as the jumping off point for me to go look at the data myself. And I think that could really help focus us and eventually lead us towards more sophisticated monitoring tools, and monitoring tools can lead towards more sophisticated investigations into intervention and hopefully improve outcomes. So, for the past couple of months, I guess, being able to extract gigantic data sets and use generative AI to help me find signals in the noise is what I'm most excited about.
Perfect. It was really, really impressive to hear. So my last question is that many of the students who will be listening to our recorded session would be considering neurology as their career. So for those who are interested eventually in pursuing the neurocritical care, do you suggest any particular skills or hobby that a student should start to begin developing early in their career, early when they start to pursue medicine?
Yeah, I'll say have start with the end in mind, right? What do I want to do? What do I want to be? I want to be a neurointensivist. So what skills am I going to need? Those skills, very importantly, is when entering medical school or considering residency, is not just neurology, not just knowing how to name the different squiggles in the brain and not knowing how to tap on knees, but knowing how to network, knowing how to emerge as a leader, knowing how to run a team. Right? These skills of being a neurointensivist, of taking a chaotic situation and walking in the room and saying, okay, we're going to treat this. We're going to do this study. We're going to understand this illness, and we're going to treat this person. So developing those skills of how to lead a team and finding mentors who can help you with that, I think, is critical very early on. A lot of what we do, like many other specialties, is speaking a common language. So getting involved in the language of neurocritical care, talking about brain monitoring, talking about coma, talking about disorders of consciousness, obviously talking in proper terminology about neurological syndromes, neurological signs and symptoms, and understanding the limitations. I also say that neurocritical care, we tend to work hard and work a lot because it's an intensive environment we work in, right? In an intensive care unit. Some practice models are shift-based with a day float, night float system. Some are week on, week off, and there's everything in the middle. So also make sure you have a mind for that you're looking for down the road. So when you're thinking about residencies and fellowships, you can ask those sorts of questions, because how you craft your life to support your work and vice versa is really important. I'd also say that communication is a really critical skill for neurointensivists that people should work on early on. The communication around asking the right questions about a person or their loved one's values, goals, hopes and dreams and aspirations, and learning to put your biases aside early so you can individualize your care for your patients. When we have these difficult conversations about their injuries, their prognosis, our next steps, which might include compassionate withdrawals of life-sustaining therapy, facilitating a comfortable and dignified death, is part of the process. And sometimes that's the hardest part of learning how to be a neurointensivist. It's not the reading a CAT scan. It's not the diagnosing a stroke. It's not the picking the right med for status epilepticus. It's having the humility and the compassion to have a real conversation with family. That takes time. Sometimes takes time over many days. And to be both confident and compassionate. Speak when you need to speak and listen when you need to listen. And communicate all this very complicated stuff that even other doctors don't understand. Communicate it down to a scared family member about what this means for their loved one and how that might change our care. And so building those communication skills early on, I think, is critical. And those are the type of things you don't learn about in your neurosciences coursework in medical school.
That was a really great answer, especially I completely agree that how much those leadership skills and teamwork, and especially the confidence and the compassion that is required in communication with your team and with the patient as well are important. And I guess in every subspecialty, these skills are really important. At the end, thank you so much for your valuable insights, Dr. Kornbluth. We were truly honored to have you with us. We are really grateful on the behalf of our whole team of Science for sharing your time, for sharing your experiences, for your expertise with us. It was really nice talking to you. To everyone watching us, thank you for listening, and we will hope you all will join us for the next time as we continue exploring different subspecialties with experts around the world. Thank you so much, Dr. Kornbluth, again.